Managing the patient's respiratory secretions is a fundamental care for ICU patients. Retained secretions can result in atelectasis, impaired gas exchange and infection. A number of potential interventions exist, each with a role in the ICU. Suctioning to remove upper airway secretions in a mechanically ventilated patient is an important skill in the ICU. Without proper technique, the patient can be exposed to complications such as airway damage, accidental extubation, impaired gas exchange, and infection. The respiratory mucosa is extremely delicate and is sensitive to rough instrumentation. A careful approach is required and should ideally only be performed when necessary. Routine suctioning should be avoided. Careful consideration to sterile technique and personal protective equipment is important, and hand washing, goggles, gown and gloves are a minimum requirement if open suction techniques are used. The patient is usually pre-oxygenated by applying 100% oxygen for 1 minute prior to suctioning. Many ventilators have a suction option that allows for this for a short period, say 5 minutes, before reverting to baseline settings automatically. In specific patient groups, such as those with raised intracranial pressure, sedation should be considered prior to suctioning. The catheter selected should be no greater than 50% of the diameter of the airway through which it is inserted. This allows for entrainment of air through the ETT, preventing the generation of potentially harmful negative intrathoracic pressure swings. Using a sterile technique, introduce the suction catheter carefully into the airway, maintaining control over the endotracheal tube at all times to prevent dislodgement. One hand should control the tube while the other feeds the catheter. The catheter is gently advanced until resistance is felt. Contact with the carina in non-paralysed patients can precipitate a cough reflex. It is important that the airway wall itself is not directly suctioned, which may cause damage. To avoid this, gently withdraw the suction catheter 1 to 2 centimetres prior to the application of suction. Suction is applied intermittently as the catheter is withdrawn, gently twirling the catheter as it is pulled back. The entire process should take no more than 15 seconds. Saline flushes are occasionally used in an attempt to liberate secretions. Evidence suggests that this has limited beneficial effect and may be harmful. Careful suctioning includes use of relatively low pressures, such as no higher than 150 millimetres of mercury, and only using suction when it is indicated. Hypoxia is an often described complication of suctioning, but is limited by the proper application of pre-oxygenation. In an attempt to prevent contamination of the airway and of the environment, and to reduce the use of disposables, inline or closed suction systems like this have been developed. A plastic sleeve contains the catheter when not in use, protecting it from contamination. These systems are easy to use and relatively uncomplicated. Care should be taken to ensure that they properly withdraw from the airway to avoid increasing resistance. Evidence comparing closed and open systems have not found a difference between the two in the incidence of ventilator-associated pneumonia. However, they are widely used because of their convenience of use. A common misconception with closed systems is that they prevent the loss of PEEP associated with disconnection. This is not true. The application of suction immediately causes this problem in both techniques. A number of drugs have been used in an attempt to break up secretions to make them easier to clear. These drugs, including N-acetylcysteine, Dornase alpha and bromhexine, have not been shown to make any difference in clinical practice, though the available evidence is very weak. Physiotherapists are an integral component of ICU care. Their roles include assisting with positioning and mobilisation, specific methods for clearance of sputum, neuromuscular rehabilitation and recovery, and cardiopulmonary rehabilitation. Physiotherapy provides an essential set of tools that facilitate removal of secretions, prevent and treat atelectasis, and improve oxygenation. These tools can include hyperinflation manoeuvres for lung recruitment, percussions and vibrations, and assistance with suctioning. Manual hyperinflation is a technique designed to recruit collapsed areas of lung. MHI is performed by connecting the patient to a gas-filled bag circuit such as a Mapleson C or Lardell self-refilling bag. The patient is given a larger than normal breath, up to 50% greater than baseline. The breath is usually held to improve recruitment of atelectasis before release of pressure, which allows passive exhalation. A rapid release of pressure may also precipitate a cough and facilitate sputum clearance. Potential complications include de-recruitment due to a lack of PEEP, bronchospasm, discomfort and barotrauma. High thoracic pressures can cause cardiovascular compromise and increase in intracranial pressure. Patients with high FiO2 or PEEP levels may not tolerate disconnection from the ventilator, which can promote worsening of de-recruitment of lung. In most patients, however, the procedure is well tolerated, though consideration should be given to adequate analgesia prior to its performance. In recent times, this process has been replaced with ventilator-based hyperinflation strategies. This technique is very similar to the manual technique, but has advantages of not causing loss of PEEP, exposure of staff to respiratory secretions, and comfort for the patient. Available studies suggest they have equivalent effects on short-term outcomes such as oxygenation. When in doubt, it is always best to seek a consultant opinion before proceeding. In theory, retained secretions can be mechanically dislodged from the airways by application of percussion to the chest wall and vibrations of the airway gas. Percussions are a rhythmical chest clapping performed over a period of minutes, while vibrations can be imparted using specific exhalation valves. Vibes can also be performed by applying high-frequency compressions to the chest during an exhalation, as if to shake the secretions loose. These techniques are thought to be most effective when performed at higher than normal lung volumes. The strongest evidence base for physiotherapy in the ICU supports early mobility and rehabilitation programs. There is little evidence for or against other strategies described, as most studies are methodologically weak, conflicting in outcome, or lacking entirely. A recent meta-analysis concluded there was no evidence that regular chest physiotherapy in ventilated ICU patients was superior to standard nursing care. Assisting the patient with sputum clearance is an essential component of quality critical care. Careful suctioning, combined with targeted physiotherapy, can prevent sputum retention that can lead to atelectasis, respiratory failure, and pulmonary infection.